Hello, how are you doing today? So, you are welcome to another aspect of the tutorials. And this topic is a very high yield topic. Whether you like it or not, you might meet this topic in probably you're asked to write an essay, or probably you are on the ward and you have to take history and manage a patient with heart failure. So, I promise you, this is going to be straight to the point. What you need to pass, what you need for the exam on point, this is what you would likely need. So just follow me in this teaching. Now, before we move further, there is that subscribe button that you are seeing. Don't be in a rush. Click that subscribe button. By subscribing, you will help me promote my videos, and the algorithm will allow my videos pop up faster. So click that subscribe button. Now, let's continue. You've taken history from a patient with heart failure, you've examined. Now, the examiner says, how will you manage this patient? You don't just start saying, I will do this, I will do that. There are ways to say it that would actually make the examiner give you good marks. So, the first thing you want to say is, sir, this is how I'll manage this patient. First, I would like to carry out some investigations, and the aim of my investigations will be to confirm the diagnosis, to roll out differentials, to detect complication, and to prognosticate the patient. Then the next thing you want to say is, also, sir, I also want to relieve the symptoms, identify and treat precipitants, identify and treat etiology, prevent recurrence and retard deterioration in cardiac function, and improve the quality of life. Now, after you've said all this, I'm sure your examiner will be like, oh, this person actually knows what he or she is saying. I can promise you, you've actually impressed your examiner by just giving him or her these principles of management. Now, you want to, the next thing is you want to, the investigation. The first thing, now in managing a patient with heart failure, at least there are the first four investigation that you should see. Are you getting me? Should be chest X-ray, echo, ECG, then serum BNP. First see those four. It will impress your examiner. So chest X-ray, we have the ABCD, alveolar edema, Kelly B lines. Are you getting me? Then cardiomegaly, enlarged heart. Then you see upper lobe diversion. Then you can also see pleural effusion. Those are your likely findings that you likely see on chest X-ray. Then the next thing you want to do is you also want to request for an echocardiography. Now, what are the aims of echocardiography? You tell your examiner that, sir, I want to assess for structural. I want to assess the structural for structural and functional assessment of the heart. Then you can also detect presence or absence of valvular abnormalities. Don't forget, in the etiology of heart failure, valvular heart disease is also an important etiology. So you tell your examiner, with the aid of echo, I could detect the presence or absence of valvular abnormalities. Also, I could also detect regional wall motion abnormalities. Are you getting me? Now, when you are seeing regional wall motion abnormalities, it's a pointer that there was a prior MI in that area. Then you also want to see that, sir, I also want to assess it. You also want to say that it is also important in assessment of heart failure with preserved ejection fraction. Also, I also want to estimate the right ventricular size and measure pulmonary pressures. Are you getting me? Because some patients could also have pulmonary hypertension too. Then you also want to see that with the aid of echo, I can also detect intracardiac clots. In patients with heart failure, because of the reduced wall motion, they have a high tendency to forming clots. Just say these few points. You might not even say the whole 6 points, but at least say three. your examiner would know what you mean. Then on ECG, what are the likely things you might see? Sinus tachycardia, a prior MI. That not all patients will have MI, but a prior MI is likely the precipitant of this current heart failure is MI. You could see atrial fibrillation, left atrial enlargement, left ventricular wall hypertrophy, biventricular wall right ventricular wall hypertrophy. You could even see other forms of arrhythmias. These are the likely things you would see on ECG. Then the fourth key investigation is plasma BMP. Now, values greater than 100 picogram per mil is suggestive of heart failure. The examiner might now tell you that okay, that at what value is highly suggestive, greater than 400. That is for plasma BMP. Now, other investigations that you like to do are cardiac troponin I and T, full blood count plus differential, and you know that full blood count and differential, when it can help you detect infection as a precipitant, and you'll be seeing elevated WBC. You can also see neutrophilia. Are you getting me? Then clotting profile too. It is also important because in the management of this patient will need anticoagulants. Are you getting me? Then fasting lipid profile. Are you getting me? Then electrolyte and creatinine to know the function of the kidneys, because one of the complications of heart failure is prerenal AKI. Then fasting blood glucose and 2 hours postprandial. The patient might be having diabetes. Are you getting me? And the patient might not know. So you also need to check for that fasting blood glucose, 2 hours postprandial. Then urinalysis. It's also very important. Now, having done those investigations, you now tell your examiner that, sir, in my treatment, I will counsel the patient on my diagnosis. Don't be too forward. You should say that I will counsel my patient on my diagnosis, my treatment modalities, and the prognosis. Now, you will see that using the goals of management which are stated above, the treatment can be achieved either through pharmacological means or non-pharmacological means. You are actually whetting the appetite of your examiner. He actually wants to hear what you have to say. Now, pharmacological, give intranasal oxygen. Are you getting me? Then you want to relieve congestion by giving diuretics. And the common diuretic we use are loop diuretics, thiazide diuretics, furosemide, torsemide. At least just say furosemide and move on with it. Don't waste too much time. Then the next thing, we've given oxygen, right? We've relieved congestion. Then you also want to reduce preload and afterload with ACE inhibitors or ARB. Now, you need to know that, at least know an example or even 2 examples of each of these drugs. ACE inhibitor, lisinopril, thiapil, ramipril. ARBs, that's okay. ARBs examples are the telmisartan. Are you getting me? The okay, we have the candesartan. Okay, we even have valsartan. So, having done that, then another thing you want to say is, I also want to administer aldosterone antagonist. An example is spironolactone, and this improves both morbidity and mortality. Okay. The next thing you also want to say is, I want to give agents to improve cardiac contractility, such as dobutamine and dopamine. Because the thing is, you see, at times patients with heart failure, they could actually come in shock, and you actually need these inotropic agents. Now, another key thing to say is, you also want to give vasodilator therapy to relieve pulmonary congestion, and we make use of hydralazine isosorbide nitrate. Then you also want to administer digoxin for patients with atrial fibrillations. Then it will be actually, you can't just go like that without mentioning these other 2 drugs, because they are now drugs that we are now using in our clinic. SGLT2 inhibitors. They've been shown to improve outcome in heart failures, and examples are the dapagliflozin, and the other one is empagliflozin. Then you also need to tell them about the angiotensin receptor neprilysin inhibitor, and the example is this combination sacubitril valsartan. Now, having mentioned this, I can promise you, you have actually impressed your examiner. You move on to see, still on the pharmacological treatment. Now, infection could be a precipitant. You need to give antibiotics. Are you getting me for this? Then anticoagulants. Now, anticoagulants, there are two groups. We have the vitamin K antagonists and the direct oral anticoagulants. Are you getting me? Okay. An example of all these direct oral anticoagulants are you have a dabigatran. Okay. Then you also want to give statins. Your rosuvastatin is very important. It's an antilipid. Then you also want to say, sir, I also want to vaccinate this patient against pneumococcal disease and influenza. The thing is, patients with heart failure, they tend to come down with recurrent pneumonia from pneumococcal and influenza organisms. So you need to give vaccination against that. Now, following, we also have non-pharmacological, and you say you want to recommend initial bed rest, nurse in cardiac position, restrict sodium intake to less than 2 grams per day, or sodium chloride intake to less than 6 grams per day. You also want to restrict fluid, no IV fluid at all. Okay, then stop cigarette smoking and alcohol smoking. Then it's also important you tell your examiner that you also want to recommend dietary and lifestyle modification. You counsel the patient to adopt the DASH diet. Okay, now beyond the non-pharmacological therapy, we also have some other interventional therapies also, such as pacemaker. I'm sure by the time you get your examiner might tell you that might tell you to round up. But just to speak further, interventional therapies include pacemaker insertion, implantable cardioverter defibrillator, cardiac resynchronization therapy, insertion of intra-aortic balloon pump, ventricular assist device, extracorporeal membrane oxygenation. These are just other interventional therapies. Are you getting me? Then we also have surgical therapy, which we have cardiac transplant, yes, cardiomyoplasty. It's, like an this is like an addition to this slide. I actually added complications of heart failure, and I also added precipitants of heart failure. So now when you're talking about complications of heart failure, because they can ask you, mention 3 complications of heart failure in this patient. Prerenal ischemia is one of them. Hyponatremia, thromboembolism, atrial and ventricular arrhythmias, impaired liver function. That's where you talk about the cardiac cirrhosis. Then sudden cardiac death. Okay? Sorry, sudden death. Okay, then precipitants of heart failure. This is very important. You need to know this because you can be asked. An examiner just come and just want to just give you one question and say that, okay, now you have managed this patient with heart failure. Did you rule out precipitants? If so, what are the precipitants you ruled out? Are you getting me? So myocardial infarction is a precipitant. Intercurrent illness, so that pneumonia, UTI, arrhythmias, accelerated hypertension, drugs such as steroids and NSAIDs, pulmonary embolism, pregnancy, thyrotoxicosis, intravenous fluid overload, unaccustomed exercise, dietary indiscretion, so that's salt intake, endocarditis, disease progression, and poor drug compliance. All these are precipitants of heart failure. Now, I can guarantee you that at least if you're able to master this, you would have something substantial to say, and it won't be hard for you to marshal your points and convince the examiner that you've actually passed. So, you stay tuned for subsequent videos and lectures regarding management of some key medical conditions in medicine. Like I said, please do not forget to subscribe. Thank you so much.